Great. Hello, everyone, and welcome to the COVID Neuro webinar, which is being followed by our first WHO Clinical COVID Neuro Exchange. My name's Professor Tom Solomon. I'm a neurologist here at the University of Liverpool and director of the HPRU. And never mind what I'm director of. Too many things to think about. Let's move on with what the plan is today. First of all, I'm going to introduce the participants in the COVID Neuro Global webinar. Helena.
Hello, my name is Helena Radbruch, and I'm by training neuropathologist. I started with neurology, but then somehow I stuck in pathology. So during the COVID-19 pandemic, when it first arose, we said the pathologists should be the ones that at least participate in resolving open questions about on the pathophysiology of the virus. So I start with them.
Thanks, and we'll be hearing from Helena and her fantastic recent publication on all the pathology shortly, and then we're going to hear from Ben. Do you want to introduce yourself, Ben?
Hi, my name's Ben. I'm one of the Royal College of Psychiatrists Foundation Fellows, work in the northwest of England, and I'm on the JNMP blog of the Neuropsychiatry COVID-19. And today I'll just be giving a 5-minute quick digest on the latest literature there.
Great, thanks. And then Tom Pollock.
Hi, my name's Tom Pollock. I'm a clinical lecturer at King's College London and a neuropsychiatrist working in South London. I've got a long-standing interest in the neuropsychiatry of infection and also encephalitis.
Fantastic, thank you. And then, so that's the COVID Neuro webinar, and then we're going to be handing over to Ben Michael and team who are going to do the WHO COVID Neuro Clinical Exchange. Ben.
Hi everyone, I'm Ben Michael. I'm a Senior Clinician Scientist Fellow and a Consultant Neurologist working with Tom. And we're delighted that today will be our inaugural COVID Neuro Clinical Exchange platform, which is a collaboration with the WHO's Neurology and COVID Global Forum. And it's really building on the great success of these webinars where really great quality of published or polished research is presented, that we realized there was an opportunity for us to get together and exchange our on-the-ground clinical experience of managing these patients. We've all valued preprints in 2020, and this is the preprint of what we're seeing on the wards, and we hope you can join us. Thanks.
And then, so as part of the team for the COVID Neuro Exchange, Ben, you were going to introduce your team.
I was. I got excited with my preprint analogy. My colleagues in this endeavour are Professor Kieran Thacker from Columbia and Dr. Greta Wood from here in Liverpool, and our presenter today will be Dr. Amy Ross-Russell from Southampton. Thanks.
Great, okay. So let me just share my screen just to give you a tiny bit more background. Hopefully you're seeing that. Give me a nod if anyone is seeing that. You are, great, okay. So we've been doing these COVID Neuro webinars for many months now, and as Ben said, we've heard preprints and published prints and even some published preprints. And today we're going to be hearing about olfactory transmucosal SARS-CoV-2 invasion as a port of entry into the CNS, this brilliant paper that was published a few months ago. Then we've got the updates from Ben, and then Tom Pollock is going to talk about psychosis. That's from 1 till 2. Why do we do these? Well, it's to bring the global community working on COVID neuro together to better understand the neurological presentations and complications, and indeed long-term effects, and to keep people up to date with the latest literature. And then in addition, we've got this clinical exchange, which is about discussion of individual cases. And we're hoping that these will expand regionally. And that will be from 2 till 2:30 p.m. GMT. Now, we always like our audience to interact, and we know that there are 422 people registered today, which is fantastic. So what we want you to do is just post on the chat function of the Zoom, or if you're watching on Facebook, you can post it into the chat function there. And first of all, let us know where you're watching from and whether this is your first attendance at any of these events. So say hello on there and let us know where you're listening from. You can also tweet if you wish. My twit thing is @RunningMadProf. And we're also interested in feedback at the end. So before we close the Zoom, you can just post any comments that might be helpful to us in terms of feedback. Anyway, without further ado, I will stop sharing my screen and I'll ask Helena to share her screen, and we can get started and hear all about this wonderful study that she's led.
So yes, hello everybody, also from my side, and I will start with the pathology part. And I'm from Berlin at the Charité, and yes, we are here now. We are the German Reference Center for Coronavirus from the virology part. So yeah, this was almost a duty to get into coronavirus research. Also, if we are coming from different backgrounds. So as the anatomical proximity of the neurons and the nerve fibers in the olfactory mucosa, and together with the clinical symptoms that the patients describe as loss of smell and taste, headache, etc. Yeah, we said we have to tackle the entrance of the virus, and if maybe like other viruses, also the coronavirus of SARS-CoV-2 is using this as a route to enter the CNS. And yeah, were studies of viral RNA in the brain and in the CSF, but yeah, the genuine virus is quite difficult to prove that it's in the CNS from others, and I will show you in a minute how we address this. So from patients with severe COVID-19 that died with COVID-19, we took several regions, samples. And during the autopsy, we established a rapid autopsy program with our ongoing biobank, and then included the COVID patients into this program. And as you can't do experiments with humans on a dynamic phase, so we just sampled in all patients the same regions, and then wanted to find out if we can by there see somehow a gradient of viral load in the different pathways of the olfactory fiber tracts. So we sampled the olfactory mucosa directly beyond the cribriform plate with the olfactory sensory neurons in it, and then the olfactory bulb just on the other side of the cribriform plate, and then its way through the CNS, and as a control also the other routes of entry, as for example trigeminal nerves in the trigeminal ganglia, or in the medulla where the respiratory control center is. We sampled, and the cerebellum, just as for example via the bloodstream, was also a possible route of entry. And here you see depicted on the right the somehow quantified, so the logarithmic value of viral copies per 10,000 cells, as for example in the olfactory bulbs there are only very few cells, and compared for example to the olfactory mucosa. So this is relative calculated on the 10,000 cells. And you see the high values in the olfactory mucosa, and every symbol depicts a single patient. So the purple triangle here is also depicted here. So they're patients with high viral loads in the nose, have also viral content in the olfactory bulb. And so we used always clean instruments to take the new samples to avoid cross-contamination. And we also sampled other regions, so this is not always that all regions are positive. And we also saw that this viral load in the CNS, so in the olfactory bulb, or then furthermore in the medulla, are depending on the disease stage. So in the early disease stage, so in the first 14 days after initial test, the patients show very often the viral load. So these 3 patients are all patients that had only very short disease stage. And in the later phases, almost never detected virus in the samples. So then in the nose, we wanted to know where are these is the virus located. So many epithelial cells were infected, but we also could detect neurons. Here in purple, it's neurofilament stained cell, with yellow the SARS-CoV spike protein. So this is not SARS-CoV-2 specific, but together with the PCR result of this same sample, we think this is strong evidence that the neuronal cells in the olfactory mucosa get infected. But as I said, this is probably not the only way. So not only via the olfactory route, but also via the vessel walls. So in the CNS, we detected. So some patients had also positive results via the PCR in the medulla, and yeah, we only found it reliable in the vessel wall. So these tiny red dots is again the spike protein, and this is in the medulla, in the respiratory control center, in the vessel walls. We find the spike protein. Interestingly, in acute infarcts, we even see more vessels with more spike protein. This is a patient that died with an acute infarct in the thalamus, and there you see these tiny red reaction products again. So directly in the neurons or CNS parenchymal cells, we could not detect the virus. And yeah, I will come to this in a minute, as yeah, I think it's very challenging to address the GNN virus in the CNS per se. But so for us, the brain vasculature belongs to the CNS, but no, if you are interested, if the neurons in the CNS are infected, I think this is very rare. But if I go back here to the viral load, you see that in the CNS, so the olfactory, the viral load is even lower, and it's around this level also in the medulla or the cerebellum. And so already, if you calculate how many cells you have to look at to find a viral particle, you have to look many hours. So, but what we see is a very, very strong inflammatory imprint. So in the CSF of these fatal cases, we see a strong increase in markers that are attracting monocytes, macrophages, and also compared to controls with this herpes encephalitis, so other viral encephalitis patients, and also compared to sepsis. So because many of the COVID-19 patients, when they died, they had bacterial superinfections in the lungs and aseptic conditions, and so we see an upregulation of microglia and activation of microglia markers. But in the COVID-19 patient, this was very, very prominent, let's say. So we want to investigate this further, and this is now unpublished, but the way we want to go, so to analyze the functional impact of this inflammatory imprint and the changes in the vasculature, etc., and by single nuclear sequencing and and proteomics approach. And if you as I said, the patients cluster very nicely between the chronic cases, acute cases, and controls. So apparently there are different mechanisms and regarding to the disease stage where the patients when the patients die. So now I come to the proof of the virus, because who has seen SARS-CoV-2? We don't want to support any denying theorist or QAnon, etc. So we took the advantage of electron microscopy that is established in the normal diagnostics and neuropathology, and detected here these virus in the olfactory mucosa. And the tissue is very delicate. After the people are dying, the tissue starts to digest itself and is destroyed. But so it's very challenging to get good quality tissue for these analysis. But yes, here in red colored, you see the viral particles, and in yellow here the cilia for the epithelial cells. But as in the literature, there are many publications, even in very high-ranked journals, where structures are published that lack either sufficient image quality or the ultrastructural features of clear identification of SARS-CoV-2. I want to here, raise your attention to how the real virus looks like, because normally the images that are drawn, the comics, you see with the spikes very prominent, but when you want to see it in the tissue, then the image is quite different. So I think, yeah, we as researchers have to our responsibility to. We started to push a discussion in Lancet end of last year, where we claimed that there have to be definite criteria that have to be fulfilled morphologically to state that these are viral particles. And I think, yeah, it's clear that in the rush of the pandemics, papers get published, maybe even not with peer review and with misleading information in it, but that now we are at the end of the second wave, or I don't know to say if I can say this, but that we come back to more thoroughly reviewing what we see and to evaluate it. So, and all the study could have not been done if it's not very interdisciplinary work with the virology, with the pathology, neuropathology, and the infectious departments, etc. So yeah, thank you to all the colleagues in the background that supported this work. And here the next webinar stated here.
Thank you. Thanks very much, Helena. That's really super. A very challenging area, I think. I would ask people to post any questions or comments that they have into the chat function so that we can see them there. And also, if any of our other panelists have questions or comments, please just turn your camera on and join us. But maybe I can start first of all. I mean, I think your data were very thorough, and you know, it was a fantastic publication in Nature Neuroscience. And I think you said you found virus, obviously, in evidence of spike protein in cells, but not in neuronal cells. And yet we've seen other publications where people say they did see virus positive staining in neuronal cells. What do you think's happening there?
I think the immunohistochemistry is very challenging of the coronaviruses, and also we had some signals in controls. So we thought that this can maybe part of other coronaviruses that cross-react, that are in the brain more normally, but also you get some sort of unspecific staining, let's say, from cells that show a reaction product, but also in the controls. So I think I can just say that the first controls were completely bland and negative, and we were very excited. Then if you stain more controls and controls, then you say, oh, okay, we have to
some of those. And I think the publication I'm thinking of, I wish I could remember where it was, because I would say, I mean, I can't remember, and I'm not completely up to date, but there was one which talked about a lot of positive neuronal staining, or some, and they didn't have control tissue anyway, did they?
Yes.
Which one? And was that the one in New England Journal, or which one was that?
There's one in New England Journal stating that it's neurons, and they don't show the controls. Yeah.
Ben Michael has a comment, and then I can also see some questions and comments in the chat. But Ben,
thanks. Yeah, Helena, I mean, congratulations on. I mean, it's just the most elegant work, and clearly a hugely valuable cohort to study. Given what we're seeing clinically in terms of concerns around endotheliitis and vasculopathy, etc., and in light of your findings of SARS-CoV-2 predominantly infecting endothelial cells in the brain and the inflammatory response, have your team yet done any confocal microscopy or other approaches, such as laser capture, microdissection, etc., to evaluate where the inflammatory mediators are coming from in that cascade that might help point us towards treatments? Thanks.
So what in the single nuclear sequencing, what we see there, that it's really changing the microglia, so that they are one major player in this, and that they show also metabolic changes compared to septic controls. So first we had other controls, and we just had very interesting findings, but they were not holding if you take the right, at least what we think is right control, so a septic patient also on the ICU with ventilation, etc., treated with steroids, and it's nevertheless we see a metabolic change in the microglia. So we don't know if this is then also functionally impacting the neurons in their function.
Thank you. Let me feed in. We've got quite a few questions now in the chat function and also in the Q&A. First of all, can you envisage any preventative therapies? This is from somebody called Seppo, based on the olfactory mucosa data from Seppo in Finland.
Yeah, so what we saw is if there is a really high viral load in the olfactory mucosa, the more probable we find now virus also in the CNS. So the most preventive thing I could think of would be to prevent high viral loads in the in the olfactory mucosa as the general thing. Yes.
Do you think, another question from, I think, Seppo as well, do you think the virus is propagating in olfactory neuronal cells and spreading from there? Is it actually replicating in those cells?
So what we see is a loss of these. So normally when a cell gets infected with a virus and then the virus replicates, these cells are dying, no? And we see this. So it was very hard to find actually neurons that are still there and that contain virus in it, because we see a very, very high loss of olfactory neurons in the nose of the severe affected patients.
A question from Ashvini. In the small numbers who had evidence of olfactory bulb spread, apart from the high viral load in the olfactory mucosa, were there any other potential risk factors in those cases in the history?
So you mean of Parkinson's disease or neurodegenerative disease, or so now the cohort is even bigger. Now we have 90 patients with a big second wave we had here. Yes, there are many patients also with neurodegenerative diseases, but yeah, we don't see any correlation that these are stronger affected or not. It's more that on the acuteness of the disease. So somehow that this maybe then the olfactory neuron gets infected and then the virus goes via the axon into the olfactory bulb, and maybe then also the second neuron, but then yeah, it's not then replicating. So we don't I can say we don't have any hints for subgenomic RNA also in the CNS. So at least we don't have any hints for reproducing virus in the CNS. I think this is quite reassuring.
Yes. These are related questions, actually, firstly from Shima and then from Iman, but I'll put them all together. Have you tested biopsies from olfactory epithelium in living patients who survived the disease? And secondly, from Iman, were the viral particles still viable in late cases in the nasal mucosa? Were they still viable and infective in those late cases?
So this is something our colleagues in the virology department did. They tried to infect then cell lines with these autopsy samples, and so far they could not infect with these. But then these people are already dead, so I think this is one major limitation of the study. And so leading to the first part of the question of the biopsies, we did not do that, but I'm just reviewing a paper that is doing this and seeing the same thing.
It is, you are seeing the same thing in that paper. Okay, brilliant. And then finally, we have more questions, but we better stop for the moment. This is a question from Tom Pollack, who's one of our speakers shortly. Given reports of OC43, this is another coronavirus causing encephalitis before this pandemic, can you comment any more on the capacity of existing endemic coronavirus in terms of invasive potential? In other words, do we know what happens with current coronaviruses, the seasonal ones? Has anyone ever looked whether they invade the mucosa?
So this is something that I asked our virologist, and because normally nobody, at least almost nobody, was interested in this seasonal coronaviruses, and this is also, I think it's very similar to other coronaviruses, the invasive potential that we see. So, but yeah, it's not 100% proven that I can, but just now overviewing our data set, I would say it is similar.
Great, thanks very much. Well, next we have Ben Cross, who, Ben, if you want to start sharing your screen and turn your camera on. Ben, thanks very much to Helena. Ben is going to now give us our JNNP blog update, which is a brief update of some of the latest publications.
Yeah, so my name's Ben. I'm one of the Royal College Psychiatrists Foundation Fellows, working in the northwest of England, and I'm also one of the team members on the Neurology and Neuropsychiatry of COVID-19 blog. You can see my slides, there we go. So basically we've got 5 minutes just to sum up kind of 5 of the latest neuropsych papers of COVID-19. as featured on our blog. So first up, we have this paper from the group in Oxford. It's a preprint paper at the moment, so it's still in process. It's quite a large study looking at 236,000 survivors of COVID-19, and they used an online electronic notes record system to basically try and figure out the incidence of neuropsychiatric complications within 6 months of a COVID-19 diagnosis. And they were also able to relate the incidence to previous infections, so influenza and other respiratory tract infections. And they basically found increased risks of neuropsychiatric complications within COVID compared to influenza and other respiratory tract infections. So if you look at the graphs on the left, for things like ischemic stroke and intracranial hemorrhage, this paper really kind of compounds what we've learned already within this pandemic from both clinical practice and research, with these kind of increased hazard ratios, specifically with COVID. But then also really interestingly, conditions such as dementia, they found quite high hazard ratios as well compared to other respiratory tract infections, and with psychiatric disorders as well. And really interestingly, I think as well, Guillain-Barré syndrome, they had a reduced hazard ratio of about 0.89, indicating kind of possibly the final nail in the coffin. Guillain-Barré syndrome may not be particularly associated with COVID-19 when compared to other respiratory tract infections, as was kind of previously thought in the start of the pandemic. This paper is also really interesting in that they managed to split up the population into cohorts of hospitalized and encephalitis patients as well. And they found that those who were hospitalized and who had encephalitis were at the highest risk of neuropsychiatric complications, which further kind of adds to the idea that severity of illness may be one of the major drivers of neuropsychiatric symptom development within COVID-19. Next up, we have this paper which looked at psychiatric mortality in New York. So they took over 7,000 positive COVID-19 patients, and they split them up into 4 groups. So there's patients with schizophrenia, mood disorders, anxiety disorders, and those without psychiatric diagnosis at all. And they looked at the 45-day case fatality rates, and quite shocking finding really. They found that those with schizophrenia were almost 3 times as likely to die within 45 days of a COVID-19 diagnosis. And that's even after adjustment for clinical and demographic and medical risk factor confounding variables. And what's more interesting as well is that they didn't find a significant association with mood and anxiety disorders after adjustment, which perhaps kind of indicates that this associated mortality with schizophrenia may come from the kind of contemporary understanding of schizophrenia with the intrinsic kind of metabolic idea, which may lend itself to higher mortality rather than the usual kind of smoking, obesity, physical risk factors that come with psychiatric illness. And then we have this really interesting study from Nature, which looked at antidepressant use and mortality in COVID-19. It stems from this really interesting meta-analysis that was done looking at major depression with COVID-19, which basically found that patients with COVID-19 who are prescribed antidepressants had reduced levels of inflammation associated factors that were associated with COVID-19. So this study basically took 7,000 adult inpatients, 345 of whom were exposed to any antidepressant, and they found that antidepressants were significantly associated with reduced intubation or death after adjustments for clinical and demographic variables, which is really interesting. They found it with SSRIs and non-SSRI antidepressants as well. And the authors called for randomized controlled trials of antidepressants for use in COVID treatment. And then finally, I've just got these 2 papers really quickly. So kind of the ongoing war of direct neurotropism versus non-direct neurotropism. On one side of the coin, we've got this PET metabolism scan. So functional imaging, they took 35 long COVID patients versus matched controls, and they managed to find hypometabolism, multiple brain areas, including the amygdala, the thalamus, and the cerebellum. The authors therefore argued that they found more evidence for direct COVID-19 neurotropism. However, this is a functional imaging study, not a structural, and it's quite a small sample size as well, so it needs to be replicated in larger populations. And then on the other side of the coin, we have this quite large systematic review which looked at cerebrospinal fluid testing in COVID-19 patients who had acute neurology. And they found that overall, the rates of CSF testing in this population are low. And then in only 304 patients who actually had the CSF testing for PCR, where only 6% of those 304 patients were actually positive for SARS-CoV-2. So the authors of this paper therefore argue that perhaps neuroinvasion directly is actually a rarity. So there's basically the two sides of the coin. Really interesting papers. So thank you so much for listening. If you want to follow us on Twitter, our Twitter handle's at the top. If you want to visit the blog directly, you can scan that QR code. It should hopefully take you there. And if you want to join the team as well, feel free to email Timothy Nicholson at King's College. And thank you for listening.
Brilliant. Thanks very much, Ben. There are actually some questions that have come in, but we're going to hold those to the end, because at the end we'll get everybody back on and we'll have a general discussion of some of these issues that we've all heard there. So we'll move on now. Thanks, Ben. And we'll hear next from Tom Pollock, King's College London, who's going to talk about COVID-19 and psychosis risk, real or delusional concern.
Okay, I think I'm unmuted now. I hope you can hear me. Okay, so I'm going to talk today about COVID-19 and psychosis risk, and whether or not this is something that we should be concerned about, whether or not there were reasons to suspect that psychosis risk might increase during the pandemic or be connected with infection, and whether or not there's anything we can do about it. So first off, historically, there are reasons to suspect that infection with viruses or any infection really does increase the risk of diagnosis with psychotic disorders such as schizophrenia or schizoaffective disorder. And lots of the research has come out of Scandinavia, particularly groups like the group of Michael Benros in Denmark, who have often conducted large population-wide studies looking at the risk of psychosis in people who have been infected. And you can see here in the bottom left panel that there appears to be a dose-response relationship between the number of hospital infections, hospital infections, and the subsequent risk of psychosis. And if you choose to index infection by the prescription of anti-infective agents as opposed to hospitalization, you can also see a similar sort of dose-response relationship here, and that's true for psychotic disorders as well as affective disorders. And then what's interesting, as well as there being a kind of dose-response relationship, there appears to be a kind of temporal gradient, so that in the 0 to 3 months following an infection, you are more likely to develop a psychosis spectrum disorder than you are in the subsequent months, although the risk still remains increased up to 5 years. And so this epidemiological work has really led on to a lot of work focusing on individual pathogens and how they may relate to psychosis risk. And one of the pathogens up till now, which was relatively overlooked, were the coronaviruses, although there was this very interesting paper, first published in 2009, but only in print in 2011, showing that patients with a recent onset of psychotic symptoms actually had higher seroprevalence to all four of the seasonal coronaviruses, but they also had sort of stronger immunoreactivity, suggesting that there may be some sort of etiological role for coronaviruses in particular. But again, this paper was largely forgotten until recently. People have concentrated a little bit more in terms of which viruses to be worried about on influenza. There's a lot more going on there historically, and we published a paper looking at the historical links between schizophrenia and influenza. That was published just shortly before the pandemic began, actually. And if you sort of look back historically, you know, as far back as the 17th century, you'll see that influenza was not really exclusively regarded as a respiratory illness. Back then, people spoke about the psychoses of influenza. And if you come forward a little bit to the major influenza pandemics, starting with the Russian influenza pandemic in the late 1800s, you can see in the medical literature a number of different cases or case series of acute psychoses of influenza being reported. And in many ways, I would suggest that these acute psychoses of influenza are the more characteristic neuropsychiatric sequel of influenza rather than, for example, encephalitis lethargica. But it was the 1918-1919 pandemic that really brought this home. There are a series of really beautiful papers by Carl Menninger, who collected cases of acute psychoses of influenza, up to 100 in 1 month at a single hospital in Boston, Massachusetts, and looked very closely at the phenomenology of these patients' psychosis and the timings of their symptoms. And what he wrote in these papers is really very relevant for people looking at COVID today, actually, and I really suggest you do look at them. But you can see here in the bottom left, he divided his patients into 3 groups. The first is delirium. And here you can see that there's an overlap between the respiratory symptoms and the psychotic symptoms, which you would expect in delirium. But if you go down to group 2 or group 3, you can see these 2 other groups called dementia precox, which is an old-fashioned word for schizophrenia, and other kinds of psychoses. And here you have this temporal gap between the onset of the respiratory symptoms and the onset of the psychotic symptoms. And what's interesting is that dementia precox or schizophrenia, if you followed up this group in time, he found that about half of the patients got better. And that's actually not meant to happen in schizophrenia back in 1919. It was thought to be a kind of chronic progressive neurodegenerative disease. So this paper was actually very important in kind of knocking some of the orthodoxy of that time. And in terms of the mechanisms, well, I don't need to talk to you about the different mechanisms of how these viruses might affect the brain, but it's worth pointing out that blood-brain barrier disruption, the role of pro-inflammatory cytokines, autoantibodies, which target neuronal surface antigens, and also maternal immune activation secondary to gestational exposure. These have all been discussed and a lot of research around all these as potential etiological factors in the development of schizophrenia and other psychotic disorders long before the coronavirus pandemic. And we should also be aware that, of course, during this pandemic, we're living in very strange times indeed, and there's a huge amount of suspicion and paranoia out there. One has to suspect one's friends and loved ones as potentially being infectious. And so this kind of environment is no doubt conducive to psychosis itself. And we mustn't also forget about patients being treated with steroids, for example, and other treatments, which of course can cause psychosis. So what about the cases that have been reported? Well, the papers are certainly interested in it. Some big papers have these kinds of headlines, although on the whole, these tend to actually be based on research. And sort of what better place to start to discuss the individual cases and case series than this paper, which I'm sure many people are familiar with. This is the initial coroner paper, which was published, I think, back in June. It's the report of the first 153 patients reported during a period of only a few weeks in the UK. There's a sort of case surveillance UK-wide study. And of the 153 patients, 23 were reported by psychiatrists as part of the Royal College of Psychiatrists arm of this study, which Tim Nicholson and I have been co-leading on. And you can see these are all the cases which were reported at this initial notification phase, where all we had really was a diagnosis. But you can see of 23 patients with a neuropsychiatric disorder, 10 of these had psychosis. And in fact, all of those were new onset psychosis in patients who didn't previously have a diagnosis. And you can see in the small print as well, there's also cases of catatonia and mania, which could be considered to be sort of psychosis spectrum diagnoses. It should be added that there was a bit of criticism about this paper. You know, how were we able to distinguish these cases from delirium, given all we had with these sort of single diagnoses given to us by clinicians? The initial response is, well, the liaison psychiatrists, it's their bread and butter really to distinguish delirium from first episode psychosis, but the understandable sort of need for a bit more data is there. And so we tried to look deeper into this. This is just a slide showing that the age distribution of these cases with the neuropsychiatric presentations was clearly younger than those with the more cerebrovascular stroke-like presentations. So led by Cameron Watson, who's part of our JNMP blog team, we reviewed the literature at the end of the year relating COVID-19 to psychosis risk. And there were about 48 cases that had been described at that point, all very different, but all with a reasonable degree of conviction that this wasn't just happening as part of a delirium picture. The sort of acute confusional states had been ruled out. In some cases, there were clear biomarkers that might explain the nature of the psychosis. So there have been about 5 cases of NMDA receptor encephalitis presenting with either isolated psychosis or a psychosis which only later developed into neurological symptoms. And work from the Charité, from the group of Harold Proust, has shown some really interesting results showing that in patients with COVID-19, there is the production of anti-neuronal antibodies targeting both known and probably unknown neuronal antigens, which potentially would have the potential to cause these kind of presentations. The other thing to add is, from a sort of phenomenological point of view, it's very, very interesting because many people's psychosis tends to incorporate COVID as a theme. So patients with depressive psychosis will often come and say that they feel that they had somehow started the pandemic, for example, or patients with a paranoid psychosis would feel that they're being deliberately infected by sort of malign agents. Or certainly I've seen a number of patients with a kind of manic psychosis who have come into hospital saying that they believe that they are able to stop the pandemic. They have the power to stop the pandemic. So it's interesting how thematically COVID gets incorporated into these patients. But in terms of kind of really showing that these are genuine psychiatric presentations and not just part of some other sort of encephalopathy or delirium, this is the preprint version of the follow-up study from the coronerve study. And you can see, again, about 25 primary psychiatric cases that have been described in a lot more detail than in the initial paper. This is out of a total of 267 cases with a great degree of detail. 9 of these were psychosis. And of these, it's very clear that the overlap with delirium was very minimal. And you can see on the right-hand side of this figure that although there was some overlap, and we can tell that from the temporal sequencing of events, but also from the phenomenology, the kind of symptoms and the severity of illness, the majority of these psychiatric presentations were essentially what we would describe as standalone or isolated psychiatric conditions. And again, if you look at the timing of the onset of symptoms compared to those of respiratory symptoms, you can see the difference between the psychiatric timings and the so-called delirium timings, making us really very confident that these are sort of genuine psychiatric manifestations. But of course, there is this big question that's been touched on a couple of times already. You know, this is a large denominator. There are 110 million people worldwide that have been affected. So how can we be sure that these cases that we're seeing are not simply very, very rare consequences of any viral infection, really? And the reason we're just seeing it so often is there are just that many people being infected, because after all, you know, there is this evidence suggesting a relationship between infections and psychosis anyway. So is there anything special about COVID-19? People, to an extent, feel that they might have had their fingers burned by the Guillain-Barré syndrome stories we just heard, where all the best epidemiology now seems to suggest there isn't a relationship. And of course, we need to be very careful about attributing causality. You know, that people become psychotic in reasonable numbers anyway. It could be that these people were going to become psychotic anyway. It could have something to do, as we've said, with the medication. And we really need to be judicious in our application of criteria for causality using, for example, the Bradford-Hill criteria, as we've suggested in this editorial in JNMP. But having some good quality epidemiology would really help. And to that extent, at the end of last year, the Lancet Psychiatry, there was a study looking at over 62,000 COVID-19 cases in the USA and their relationship to new onset psychiatric diagnoses. And actually they reported that although they found high rates of anxiety disorders, and particularly sort of post-traumatic stress disorder type presentations, they didn't find a clear signal for newly diagnosed psychotic disorders, despite case reports suggesting that this might occur. So perhaps we're more in this kind of Guillain-Barré syndrome territory where the anxiety is worse than the reality. But fast forward just to this month, and this same group has now updated their analysis, looking now at 236,000 cases. And actually, this was just covered by Ben Cross in his short presentation earlier. And you can see now that patients with COVID-19 are at increased risk of the development of a psychotic disorder when you either compare them with a matched group of influenza patients or other respiratory tract infections. So at the moment, from our sort of best epidemiological knowledge, it does appear that there probably is an increased associated risk. If you look at this right-hand side diagram, you can see the sort of the top pink line. These are patients who had encephalopathy as part of their initial presentation with COVID-19, suggesting that if CNS involvement is there from the start, that might be what particularly brings the risk of development of a psychotic disorder. So more needs to be done. But in terms of the things we should be looking at now, there's one other area which has been really, I would say, severely neglected so far. And this builds on work that we've known from the 1980s, from Sarnoff Mednick, who's pictured here, who was interested in the relationship between prenatal infection and the development of psychosis. And he was aware that patients with psychosis tended to be more likely to be born in the winter months or the early spring months. And from there, he decided to look at the 1957 influenza epidemic to look at the effects of infection on the subsequent development of psychosis. And he was able to show that patients born in 1957 were more likely to become psychotic later in life than patients born in other years. And since then, that finding has been reproduced using a number of different designs, epidemiological designs, ecological designs, and also so-called sero-epidemiological designs, where blood samples from pregnant mothers have been tested and then their offspring have been followed up over time. And the idea that these patients are at risk for the development of neurodevelopmental disorders, and that includes autism spectrum disorders as well as psychotic disorders in their 20s, does appear to be reproducible. So I think as an academic community, we are really mandated now to be thinking about this right now, to be building cohorts, or to be sort of building, gathering data on these patients, and to be following up offspring born during these years, both to look for short-term potential neurodevelopmental complications, but also longer term that might only appear in the 20s, 30s, or even later. So on that note, I just want to say thank you so much to everyone from the CoroNerve study, from the sort of neurological side, particularly Ben Michael, Tom Solomon, Reese, Ian Galea, also from the psychiatric side, Tim Nicholson, Alan Carson, Eileen Joyce, Mike Dilley, but really thank you most of all to everyone who works on the blog, particularly to Ben Cross, who presented today, but also to Cameron Watson, who helped write this review, which a lot of today's talk has been based on. So thank you so much, and I'm happy to take questions. I hope you could hear me.
Brilliant, thank you. Yes, we heard everything there. So we've got about 10 minutes for questions to Tom, and also questions relating to any of the talks we've heard today. So please do join in. First question actually from Charles Newton. He's asked, is the psychosis associated with COVID-19, in the psychosis associated with COVID-19, what proportion had disturbance of smell or taste? And are there any MRI data on patients with psychosis associated with COVID-19?
So that's a really good question, and certainly listening to that the earlier talk today was a question that came into my head. That would be something that we really need to know. I don't think there's been anything reported on that, to be honest. The question of MRI findings, again, we have individual case studies. I think there's possibly a series of 3 MRI studies. You'll probably be unsurprised to hear that the majority show either non-specific or no abnormalities at all. So again, there's no clear signal there. These certainly aren't cases of clear limbic encephalitis, and there's certainly nothing more sort of serious like that. Although, having said that, many of the cases of autoimmune encephalitis or limbic encephalitis that have been described in the literature often do present with psychosis. It's just that they tend to become more fulminant in the later stages. Yeah,
and they should, of course, I said we've got 10 minutes or so for discussion, and then following that, for anyone who's joined us halfway through, we have the WHO clinical exchange for half an hour where we'll be discussing an individual case. Amy, did you have questions or comments, or are you just gearing up ready for the case presentation?
Well, no, I was just joining.
Great, thank you for joining.
Having looked through a lot of the psych cases with Tom during that, I'd second that and say that the other limitation that you've got during a pandemic is the limited resources and scanning things that are available. So you end up with pockets of cohorts to then look at, and getting data with everything is quite challenging.
Yeah, great, thank you. Ben?
Thanks, Tom, great talk. So given this, the perennial question is, what's the role of the virus? What's the role of the pandemic? When we look at community cohorts, the GLAD study and other coping and others, they actually saw declining levels of reported anxiety, but over-reporting of subjective feelings of anxiety. But you told me it's underreported when you do the actual tests on patients, but over-reported as a symptom. What do we have in terms of community level uninfected patient data in terms of the risk of affective disorders or psychosis, etc.?
So I think, as you say, data is beginning to come out from that study and a few other sort of large studies. The problem is, unlike anxiety and depression, where there are very easily administrable scales, although I would slightly question your distinction between subjective and objective scales of anxiety, because of course they're all self-report and they're all subjective in that sense. The problem with giving people self-report scales for psychosis is that they tend to be less reliably answered, and to the extent that even these sort of psychosis screening questionnaires, self-report questionnaires that we have are not always that great at screening for psychosis, possibly because of the nature of the illness. So whether or not we are going to see an increase in so-called sub-threshold psychotic symptoms, I think is a really interesting question. There's a researcher called Golem Khandekar from Cambridge, although I think he's just moved, who has looked at the relationships in large cohorts like the ALSPAC study in the west of the UK, looking at the sort of seroprevalence of antibodies to various infectious agents, and how those relate to the prevalence of sub-threshold psychotic symptoms in sort of teen life. And there's some really striking correlations between infectious exposures and these kind of sub-threshold symptoms. So these people aren't schizophrenic, they're not seeing their doctor, but they're reporting, you know, strange things happen when I close my eyes, or I sometimes think people are talking about me, and that kind of thing. And while that doesn't necessarily mean that someone's going to have a sort of necessarily have a terrible time and have to be followed up by a psychiatrist, at a population level, it probably is going to be related to a great degree of morbidity. And so I think, you know, because of the scale of this, we do need to start thinking about population level studies.
Let me just see, Helena, I don't know if you want to rejoin the discussion, and also Ben Cross, who presented the JNNP papers, because we've got some more broad questions coming in. Firstly, a broader question. This is from an anonymous attendee. Any reason why patients with probable COVID encephalitis or encephalopathy have negative CSF for the virus and a normal CSF profile? What do the pathology studies tell us about that, do you think, Helena?
Yes, I can say if there's virus in the CNS, it's probably only very little. So I don't wonder that in the CSF, there's probably no virus detectable. So yes, I think this is not excluding any virus in the CNS.
Does anyone else have comments or thoughts on that aspect of the CSF profile in relation to, I mean, Ben, you were comparing these two papers, you know, this debate about how much neuroinvasiveness there is and how much not. What's your take on that aspect from papers you've read?
Yeah, I think that paper is really interesting because it found, 6% of 305 people did have, positive PCR tests, so not the antibody tests. I think they found 12% of 45 people had positive antibodies for SARS. So it's really quite low rates that we're finding in the CNS, and I think perhaps it relates to severity of the disease and viral load and things like that. But I'm really not sure myself what's driving it, to be honest.
Ben?
The issue, of course, is you have to exclude spillover from the blood when you identify it in CSF, and knowing the cycle threshold in blood and in CSF and the albumin ratio in serum and CSF, you can make more informed choices about whether that 6% is more like 2% or 1%.
Just now we've got lots of questions coming in, so we'll try and get through these. The 236,000 survivors study, Tom, with the neuropsychiatric complications, do we know, asks Deborah, if other coronaviruses were included in the respiratory tract infections?
Ben might be the person, Ben Cross might be the person who knows the answer to this. I think because it was based on, insurance records, I don't know whether you need a sort of, I presume that they probably test routinely for influenza infection, but I doubt very much that they're routinely testing for seasonal coronavirus infection, would be my guess, but I don't know if Ben knows the answer.
Yeah, I have a feeling in the manuscript it's not mentioned, so I don't know. Specifically mentions influenza and then other respiratory tract infections. I don't think it delineates which ones.
I think they were probably diagnosed clinically rather than in the laboratory.
Great, thank you. And from Ashvini, in those presenting with psychosis in the absence of encephalitis after SARS-CoV-2 infection, has there been similar treatment responsiveness to what one would expect prior to the pandemic?
Yeah, so actually this is a really interesting thing, and it brings you back to this papers by Carl Menninger. Now there's no data, this is only clinical sort of anecdote, but certainly the patients I've seen and some of those patients described in the Coronerv study, it really suggests that these are acute and transient psychoses, where people who are really very well and don't necessarily have a history, and often are sort of outside the normal age range. I mean, that's been our experience. People in their sort of 40s and 50s, rather than their sort of late teens and early 20s, are suddenly becoming psychotic, and then sooner or later the COVID test result is there, and often in a couple of cases they've got better before people have even really had the chance to have a proper course of antipsychotics, or either that or the antipsychotics have kicked in relatively quickly, and in a couple of cases I can think of, they've actually been stopped with relatively good effect. What we're not seeing necessarily are these people who have had a kind of a chronic schizophrenia-like picture just unmasked by the pandemic, although those may sort of emerge once the epidemiology is there. There's one or two interesting patients in the Menninger studies. Was one patient that really struck me, who became psychotic once in the Russian influenza pandemic, when he contracted the illness then, and then was absolutely fine for 28 years or whatever until 1918, when he got the Spanish flu, and it happened a second time. So there may be these people who just have this sensitivity to this kind of infection, but that's speculation.
Your answer then towards the end relates, actually Amy has a question, similar question, but do you want to put that, Amy, because I think it is of interest?
Yeah, so I thought your last point was fascinating. So it was a great talk, but particularly this big question mark that you said has been neglected about sort of in utero exposure and experience, and potentially relevant to other areas of neurological disease, not just psychiatric disease. Do you have a feeling from the historic studies about when the risk is greatest, or do you have a theory about when that risk is greatest?
So there are a couple of meta-analyses that I think put the greatest risk in the first or second trimester. And I think it very much depends on what you think the main mechanism behind it is. I think the data, although it's not really wonderful data to be honest, does suggest first or second trimester, if I'm right. Now, I think if you're someone who thinks that this might be a sort of pathogenic maternal antibody that's going through the placenta, then you need to sort of be thinking more about, if I'm right, it's the first or second trimester where it's more permeable to IgG. But whereas if you think this is something to do with the passage of cytokines, or something to do with actually disrupting placental blood flow or something like that, then you might have a different answer. So again, because we don't really know the mechanism, I'm not sure we can answer that fully, but I would probably go with the suspicion that the risk might be throughout pregnancy.
Now, thank you. Now we have 1 minute left. We're going to finish bang on time to transition into the next session. But in this 1 minute, Tom, first of all, I want you to answer 3 questions briefly. Do we know, it's all right, no, you're doing fine. I'm not having a go, but just so you know where we're at. Do you know information about family history of patients with COVID-19 developing psychosis? Do they have the same genetic risk factor, or the fraction attributable to infection, is it higher?
Could you just say the very last bit? Do they have the same?
Do they have the same genetic risk? Basically, that's the question.
Okay, so family history, we don't know much, but on the basis of every other sort of organic psychosis that we know about, people with a positive family history are more likely to become psychotic once they have some sort of illness. That
was from Marino. And then from our friend Matilda, could the patients with schizophrenia die more as they receive less care in the ICU or in intensive care units, or given their difficulties to stay on ventilators, etc., etc.? Do you think that could be contributing to their outcomes?
Because they don't want to stay in
yeah, or maybe just people with psychiatric illness anyway tend to get a worse lot from the healthcare.
Yeah,
might that be contributing to worse outcomes?
Absolutely, and I think this is a whole social issue. These patients they have clearly differential access to healthcare, and that's probably both externally and internally imposed. So yeah, undoubtedly it's important.
Thank you. Now, just a few closing comments. First of all, Amanda has asked about the names of the publications, the references. All of today's talks are recorded, so you can go back and watch again at your leisure to catch up on anything you missed. We know we do get through quite a lot of information quite quickly. And somebody called Maheswar has answered the question about data on smell and taste in relation to psychiatric disease, that they weren't originally recorded as COVID-19 symptoms. So that, we know, that might be why we've not got such information there. We may get more later on. And finally, if all the panelists will come on the screen, because we've got a great question, anonymous, but they want us to vote. What does the panel think about the call for an RCT with antidepressants as suggested? So I think if panel members want to give me a thumbs up for a trial at this stage, or a thumbs down at this stage, now is your chance to vote. Thumb up or thumbs down? Oh, how interesting. Hold your thumbs. Let's see. Leave them where they were. I've got 1, 2, 3 down, 4 down, 1, 2, 3, 4 up. It's clearly a subject for another debate on another occasion, but we'll leave it there, tantalizingly unresolved. And at this stage, let me thank all the participants from the first half of today's mega event. I think Tom has to join us to go and do a clinic, but I think everyone else is going to stick around, maybe for some further discussion at the end. But let's clap those who have contributed so far. And